welcome to the Injury Podcast. I'm your host, Dr. Craig Selinger, chiropractic physician. Today, we're going to be talking about a topic that may not sound so exciting at first, but it might even be the most important topic that we've covered so far in our podcast. It is coding, billing, documentation. Most people think of medical records and documentation as just paperwork or something that needs to be done to get paid. But the truth is, medical records tells the patient's story. It describes how the injury occurred, what symptoms the patient is having, what findings the doctor found during examinations, why the treatment was medically necessary, how the patient is responding to care and whether or not they're improving, and whether the records accurately reflects the true impact of the injury. When documentation is done properly and well, everyone benefits. The patient, the medical providers, the attorneys, the families. Patients receive better care, better coordinated care, and get better and have better outcomes. The healthcare provider gets paid quicker as well, and everyone, like I just said, does better. And the attorneys also, from their perspective, they have a record that accurately tells the story of the person's injury and what happened to them. Today, we're going to discuss why documentation is important in coding and medical necessity and functional loss and so many other topics. And we're also going to talk some more about common documentation mistakes that providers can make, and also how you should be doing them properly and so forth. But before we begin, this is a disclaimer. This podcast is for educational purposes only, and it does not constitute a doctor-patient relationship, nor should this be used as advice for medical or legal billing, coding issues, or anything like that. Always consult the appropriate healthcare professional, attorney, or coding expert, or regulating authority regarding your specific situation. I'm excited today to welcome our guest, Dr. Jeff Lewin. Dr. Jeff Lewin is the CEO of New Compass Coaching, a national healthcare practice consulting firm that helps practices be able to document code more accurately and being more compliant. And it's very important that we do this. He has almost 30 years experience in doing this. He has worked with thousands of healthcare providers across the United States and internationally, and he's been helping them with various different types of issues regarding billing, coding, reimbursement, compliance, and he also has worked as the help coordinator for the Florida Chiropractic Association, and he is our guest today, and we're so lucky to have him here to be able to talk with him. So I'm looking forward to this episode, and let's get started. So, Dr. Lewin, welcome to the Injury Podcast.
Thank you so much. Thank you. It's great to be here with you.
Yeah. So what got you into coding and billing and documentation?
A great question. If you asked me when I went into chiropractic, when I first graduated from chiropractic school, 30 some odd years ago, I never in a million years would have believed I was going to be doing what I'm doing now. I believe fully that I was going to be in my practice, taking care of my patients, getting sick people well. That's what I thought I was going to be doing. About mid-1990s, I actually hired a practice coach for my own practice. Did very well with that person, and the coaching business was growing and asked me to come on board to be a coach with him. And that's how it all started. And within two and a half years, it became a full-time gig for me. I had to replace myself in practice. I was having a lot of fun, but also being married and a dad of 4 boys that were younger in those days, I couldn't balance everything and expect to do everything well. And I found that my passion had changed. It had shifted from taking care of the patients to taking care of the doctors that are taking care of the patients. And that's what I decided I was going to follow. Back in the late 90s, early 2000s, the business of healthcare, chiropractic specifically, but healthcare in general, was very different than it is today. What was required in terms of the quality and content of your documentation and how we billed and coded was very different, and it started to change, and it started to change rapidly. It's almost as if, when I first went into practice, you can say that the half-life of your knowledge was maybe about 10 years. So in about 10 years' time, 50% of what you were doing and the way that you were doing it was no longer appropriate. By the time we got to the early 2000s, that was reduced to about 5 years. And I think today, it's even less. It's probably 2 years. So if you're doing things the same old way that you've been doing all along, time to take a look and consider that maybe you need to bring yourself up to speed.
Yeah, level up. I really admire you. And I don't know how you read all those soap notes because they give me a headache. I mean, I sometimes even reading my own notes, but I give you a lot of credit because that's hard to do, and you have to, I guess, have a passion for that. And kudos to you, man. I really think that that's great that you can plow through all those notes and be able to analyze them and look for mistakes or help people improve, I should say. So,
fortunately for me, that's only a small part of what I do with my clients. But what people have come to know me for on a statewide stage here in Florida and nationally is billing, coding, documentation, and compliance, because I can take these really awful, and like you said, not the most exciting of subjects, and turn it around and make it practical so that people can understand why they need to do what they do, and be able to feel empowered with the knowledge of knowing that they're doing the right thing for the right reasons.
Right. We spoke a little bit prior to the podcast, and I remember you saying something to me that patients' records tell a story, and I want you to elaborate on that a little bit.
So I think it's important for doctors in particular to know what the purpose of their notes are, what the purpose of their records. They think it's so that they can remember what they did last time, so that they knew what to do today. And while, that is certainly a part of those, the purpose of their documentation, the real reason to have great notes is for other people, for third parties. So whether it's for a health insurance adjuster to take a look at, an auditor, God forbid, or maybe you have another doctor that's going to be covering for you, you have to write your notes with the perspective that somebody else is going to have to take a look at this and figure out what was going on. When I first started in practice, I was an associate for the first 6 months or so after I graduated. And I remember the very first day I went in to work in that practice. It was myself, and there was another associate, the senior associate. He had been there a few months longer than I was. And the guy who owned the practice tossed a file at me and says, "Write up my notes," and leaves. And I go, "Well, what should I put?" And he's like, "Write up the note." Okay. And I look over at the other associate, and he looks at me and goes, "Just put down SSSQ." I'm like, SSSQ? What is that? It's like signs and symptoms, status quo. And in 1989, 1990, that might have been not necessarily a compliant note, but it was okay. It was enough for them to get paid, and it's the end of the Mercedes 80s, as they called it, and to get paid well. Many people, they would take an 8.5 by 11 piece of cardstock, fold it in half, and put a grid on it. They'd put today's date, and then there was a check mark next to it that the patient was here.
Right.
And maybe there was some hieroglyphics, some internal code that only they can decipher to determine what was performed on that particular day.
Right.
That was the whole record.
Yeah.
Today, I don't think that anybody would be willing to try that.
Yeah, it definitely things have have changed quite a bit. And it's interesting because you mentioned different people that are going to be reading these notes. It's important to have legible notes, right? We want to make sure that people can read them and understand them. There's many different people that might be looking at them. There's many different reasons why it's important to have good notes, and we're going to discuss many different things. What there's a term that's called medical necessity, and that is I want you to explain that and why it's important that the doctor document that, and why it's so important for the patient, and why it's important for the attorney, because this podcast is the injury podcast. We mainly handle issues regarding personal injury. And why is it medical necessity important to demonstrate in your notes?
Sure. So I think before we look at the subset of notes that we would consider to be medically necessary, we want to consider anything that a doctor does as being what we would call clinically appropriate. Okay? Anything that we do, I would hope, is going to be clinically appropriate to do. But that doesn't mean that it's medically necessary. Things that are medically necessary are a subset of what is clinically appropriate. For something to be medically necessary, it needs to be therapeutic. There needs to be the anticipated improvement functionally for that patient, not necessarily pain improvement. That's nice. That, fortunately, with what we do in the world of physical medicine, is something that happens and we do exceptionally well. But what they're looking for in terms of medical necessity is improvement of function. And it has to be part of an overall care plan. So a care plan, I divide into a couple of segments. There's the overall care plan that will describe the patient's journey from the time that they enter the practice until the time that they're discharged from their therapeutic care plan. But we can divide a care plan up into treatment plans. I usually default to the Medicare definition of what a treatment plan is, and that is a no longer than 30-day period of time. Could be less than, but not longer than. So we want to break that up, and that means that we need to do a number of things approximately every 30 days to help establish the need for ongoing care, establish that medical necessity, or for us to be able to manage and measure what has been going on with that patient and say, okay, we're done, we're getting close to wrapping up here.
Okay. All right.
Care is no longer medically necessary.
Let's unpack this and make an analogy to something that many people would be able to understand better. So let's say, for instance, let's look, instead of doctors, let's say somebody from a trade like a plumber comes into the house. And the plumber comes into the house, they're going to do an evaluation or assessment of what the problem is with the pipes, okay? Maybe there's a clogged drain somewhere, right? So that's like the doctor exam. And they're also going to be very specific to that particular problem. They are going to do something that is related to why the drain won't flow. They're not going to go to another side of the house and then look at another part of your plumbing system that is totally unrelated. So when we talk about the evaluation, we talk about what's appropriate. They're going to look at the area that is the problem that you're having difficulty with. The next thing would be the plumber would do their assessment and do whatever they're going to do, and then after that, they would recommend a way to fix it, right? So the fix it part would be like the care plan, right?
Exactly.
And you want to make sure that the fix-it plan that the plumber has is going to fix the problem that you called about, that the drain is clogged and it won't go down.
Right.
So you're not going to look at, my care plan is to put in copper piping or put in some other type of piping. That might be a nice thing,
Yes.
right? But it's not going to address the immediate problem. And now we're going to say that your plumbing problem, you weren't the person paying for it. It was being paid by, let's say, your uncle. And your uncle is like the insurance company, and your uncle wants to make sure that they're not going to do everything. He's not going to pay to remodel your house, but they want to make sure that the drain is working properly. So we have to give your uncle a little bit of information to know that this is the problem, what's the bill for the problem, and what is going to fix the problem. So I think that it can get very complicated when people, when we speak in the healthcare industry, medical industry, about codes and about exams and about care plans. The care plan is just the doctor's way that they want to fix the problem. That's their approach to fix the problem. Some doctors are surgeons and they fix the problem with surgery. Some doctors are primary care doctors and they might have medications to handle certain different ways to handle the problem. So would you you think that's a good analogy, or you want to maybe add to it a little bit?
It's an excellent analogy, and it reminds me of a story. When I speak, I like to tell stories because it takes these concepts that
Make them simple.
and it brings it to life. And oftentimes there are people, and I love to look around the room and see people's heads shaking up and down, or eyes bulging out of their heads because I know I've touched on something. Reminds me of a situation with a client of mine a number of years ago. We get started early on our relationship, and he mentions in passing that he always bills a 98941 adjustment, which is a 3 to 4 region adjustment. And for me, as a coach who also understands billing and coding, whenever I hear that something is 100%, red flags start going up. So I said, back up for a second, tell me about this. Well, I'm a full spine adjuster. I go, great, so am I. He's like, well, if somebody needs to have an adjustment, if there's segmental joint dysfunction, subluxation, whatever you like to call it, if it exists, I think that we should remove it with an adjustment. I go, yeah, me too. But it doesn't mean that you have, we talked about this before, the medical necessity to be able to bill a third party for that.
Mm-hmm.
Patient comes in with headaches and neck pain. What do you have medical necessity to treat? Cervical spine, maybe the upper thoracic spine. All right. Can you take a look at the lumbar spine, patient's pelvic area? Absolutely. Can you adjust those areas? Absolutely. But there's no medical necessity. That goes back to that what's clinically appropriate, anything that you choose to do for that patient. What's medically necessary? That 1 to 2 region adjustment. So it was a very difficult conversation because I knew what the effect was going to be for that person's practice. And he's like, oh, this is going to cost me money. I hired you to help me make money. I said, yep, I get it. I don't take any pleasure from having this conversation with you. But what you don't realize is that below the surface for me, I want to make sure that you're doing everything in a compliant manner so that if anybody comes knocking on your door, you're going to be able to substantiate what it is that you did and what you got paid for and not have to give that money back, sometimes years after they paid it to you.
Right. Okay, so let's unpack some of this because there's a lot of terms out there, and the folks, we're going to define a couple of different terms here so you get a better understanding of what we're talking about. So in the healthcare world, they use codes, numbers and letters that are representing either a problem that the person has, call it what we call a diagnosis, and then there's also codes that are for treatments. Okay, if somebody gets a surgery on their neck or back, there is a number and letters that are grouped together, and that is a code that will be treating that specific problem. So there's letters and numbers that are grouped together, and these stand for certain procedures or what the problem is, which would be the diagnosis. Okay, so that's what a code is. It probably has a little bit more elaborate, but I'm trying to make it simple. The question that we're talking about here is important because insurance companies that you are covered with, they have a responsibility to make sure that they provide health care coverage to you in the event of an accident, injury, or sometimes illness, depending on what kind of insurance it is. Now, the way that they'll pay for these things is directly to what the problem is when you went to go see the doctor. So if you see a doctor for headaches, you might also have pneumonia. But because you're seeing the doctor for that specific thing, really that's what they're mainly going to treat, and that's what they're going to treat. Now, maybe that wasn't a great analogy. They'd probably treat the pneumonia too, because that could be another problem. But if you have, let's say, a heart attack, but you also have bunions on your foot, when you go to the hospital is going to feel and that you're there for a life-threatening condition. They're going to treat and address your heart attack. And you might have other health problems, but they only have clearance or an okay to treat that heart attack in this particular instance. And they're going to do different things, might be x-rays, they might do blood work, they might do other tests to see what's wrong so they can make a diagnosis, okay, and then give you a plan or a way to fix it. So that's what they're going to do to make it simple. And sometimes what happens is, what Dr. Lewin was just saying, is that people want to fix more things than what the patient's complaint was of why they came to your office in the first place. So somebody with the heart condition comes in with a foot problem. Some doctor might try to treat both. But if their complaint that they're going for in this particular case would be for the heart, that's all they really have the okay to treat and to do the testing and to give a plan for. And if they treat the other areas that are not related to that condition, to that heart condition, it could not be covered because the insurance company would perceive that that is not necessary, right?
Correct.
For that particular visit to the doctor for that condition. So that's what medical necessity, is it necessary for this particular condition that the patient has? That's important to understand. So some of these things, they have technical terms, technical meanings. Of course, everything's medically necessary. We want to be healthy, but there's exact definitions to these terms, and it's important because we want to make sure that the patient's concerns, main concern, gets addressed when they go to see a doctor. And the insurance company wants to make sure of that, and they want to make sure that it is done effectively, and sometimes, unfortunately, the cheapest way that you can do it. That's also a factor, too. They don't want to spend more money than they perceive that they should want to spend. So I'm coming up for air a little bit right now. But what are some big mistakes that you've seen in coding and billing that regarding either medical necessity in the personal injury realm?
Sure.
Let's talk about that.
So there's a number of things. So if we're going to talk about the billing and coding aspect first, one of the things that many doctors and even many attorneys are not aware of is that in the personal injury insurance companies, the auto insurance companies, when you submit documentation and bills, they utilize a program called Colossus, right? If they don't use Colossus, they utilize a program that functions just like it. And, lately, artificial intelligence, AI, is like the buzzword, and we think that things like, related to ChatGPT and Claude and so forth are like cutting edge and brand new. AI has been around for quite some time, and the insurance companies have been making use of it for quite a while. And Colossus is based upon AI as well. So what it's able to do is it assigns value or value drivers to the information that is fed into it. So part of that has to do with the diagnosis that you put down. Some of it has to do with the treatment codes. Some of it has to do with how you typically manage a particular case in personal injury as a doctor. It'll also have the same type of information on the attorneys. And it can take Dr. A and Attorney B, put it together, and within a high degree of certainty, they're going to know what their payout is going to be as an insurance company and how they're going to be able to settle that particular case. So doctors want to and should be able to understand this and give Colossus, or whatever that program is that insurance company uses, the best quality information that they can.
Right. So Colossus, to unpack this a little bit, is a software program that's a sophisticated software program used in the insurance industry to help adjusters in the insurance company get a ballpark range of what the persons that got injured's care should cost the insurance company. Now, back up a little bit. This information we're talking about right now pertains more to Florida or a state where auto insurance companies do have a health insurance component to the care that they have to provide or required to provide in the state. In Florida, that is the case. So now, those codes that we talked about, those codes about those what's wrong with me code, the diagnosis codes, all have numbers and letters. And when those numbers and letters go into that insurance company, the program scans those numbers and letters, right? And if it scans them and it says, okay, somebody lost a foot in this accident, and that's a diagnosis code for, let's say they had an amputation, they're going to require, a lot of care because they're going to require prosthetics. They're going to require extensive rehab. They're going to be in the hospital. They get an idea of how long it's going to take and how much it's going to cost, right? Ballpark range, they can get an idea. And then another claim goes in, and it is for a mild finger sprain. Their index finger got hurt, and there is a code for a sprain of your index finger. And that goes into the computer system. And the computer system software is going to be able to give a prediction or range of how much that should cost. Now, where does the problem come about with this?
Problem frequently comes about with the order that those diagnoses are reported. One of the things that I see as a common mistake is to put down a low value order diagnosis. Not low value from my perspective.
Like a minor injury, more minor injury or smaller injury.
Take a classic automobile accident. Patient for sure is going to have a whiplash type of an injury, a sprain or strain to their neck, to their cervical spine. But the diagnosis that goes in that very first position on the claim form that gets sent into the insurance company, that's the diagnosis that's going to set the tone for how that claim, that whole case is going to be handled. And if we put down sprain or strain in that first position, that is considered to be a low value diagnosis. Those are things that, it's a soft tissue injury. It's going to resolve in somewhere around 4 to 6 weeks, most often, and sometimes even without any treatment, it's going to resolve. So we want to make sure that we use the best diagnosis, not from a philosophical perspective, not from what I think should be the case, but from what Colossus says. We want to understand and speak their language. So, and there's no little box to check off on a CMS 1500 form, which is the form that doctors submit bills to insurance companies on, to indicate what your philosophy happens to be. So we want to put down the most valuable diagnosis. So there's actually a hierarchy. Okay. And in terms of value, a neurological diagnosis. If a neurological component exists, we want to put that in that first position. The next most valuable is a structural diagnosis. That can be related to the disc, whether it's a bulge or a herniation, could be degeneration that might exist for that particular patient. Then we have a functional diagnosis, decreased range of motion, joint stiffness, deconditioning syndromes that happen as a result of trauma or longstanding problems with the patient's neurology. Then we can have soft tissue, but I'm not talking about sprain strain. We're not even there yet. All right, I'm talking here about muscle spasm.
Wait, Doc. I think I need a dictionary for Colossanese. I don't speak this language, but I'm glad you do. So if you're a provider out there and you don't speak Colossanese as a second language, you really need to speak with Dr. Lewin, because this can be complicated. Bottom line, right? There is a pecking order into the way that the codes from first to the last code are should be on the HICVA form or the billing form or the note. And the ones that are more important, based upon different factors, should be more at the top, and the ones that are not as important or more minor injuries should be lower on that pecking order.
Absolutely. And then you want to make sure that you update that diagnosis on occasion. For me, when I'm coaching my clients, one of the things that I tell them is what's the purpose of doing a re-exam? It's so that you can see what's going on with the patient, measure and monitor progression or lack thereof, but it also creates a natural way for you to hit a pause button. Let's update the patient's diagnosis. Let's update the written treatment plan. Let's update things like outcome assessment questionnaires so we can see how the patient is doing with their ability to perform their everyday activities of daily living, their functions. Those are important things to do. And that re-exam time is a perfect opportunity to hit that pause button.
Yeah. So if you're thinking and you're getting lost in this and you're a patient and you're not quite understanding, bottom line, if your doctors, whether chiropractors, physical therapists, your medical doctor, or even surgeons, if they don't use the right codes, that could mean your care is denied. Your care is denied, and the insurance might not cover it. And that's important because at the end of the day, you might be responsible for those bills. So this is important. It's also important if people are filing for disability and other things down the road. So it's very important. And we have an expert in right here at the studio that we're discussing this with. Dr. Lewin, what are some stories from your clients or in their personal injury space of mistakes that you're seeing that can really be bad for the patient? One, in there might be not getting the care they needed, the referral they not needed. Maybe their MRI was denied, right? They were supposed to get an MRI, but it's denied because the codes are not correct. Or from the attorney standpoint, too, of trying to make the patient whole again, or as much as possible with the settlement. What are some of those pitfalls or problems that you've witnessed?
So I'll change some of the names and places to protect the guilty.
Okay, thank you. I love it.
You mentioned earlier that I take a look at documentation. I do reviews of documentation for my clients, hopefully on a proactive basis. So if there's things that they could be doing better, we bring that to their attention and they can make the changes rather than waiting for an insurance company or a state board or a federal agency to do the audit for them and not find some great things, and it's going to cost them a whole lot of money. It's better to be proactive.
Right.
So one of my clients that I've been working with for a long time finally got around, is like, okay, I'm going to do it. You've been on my case to do this. Let's just do it. He sends me what it is that I needed for the audit, and I take a look at his first chart, and I open it up, day one. History, exam, all the things that he did that day. Aside from some typos, it was beautiful. I was very, very impressed. So I go to day two, and it's the same. Like, even the typos are the same. I'm like, oh, maybe he made a mistake. No, the date of service is different. But what was going on looked exactly like day one. And I turned the page. Day three, same thing. What he was doing essentially was copying and pasting his notes.
Oh, wow. So, folks, every note was the same from the first day of service to the third to the fourth and so far.
All the way through.
Wow.
And I was doing this on a Sunday morning, and I was like, all right, something went sideways here. So I called him up, and he answers the phone, and I said, hey, what's going on here? This is what I see. He says to me, Jeff, I got a busy practice. I don't have time to sit there and do this customized documentation each and every time. I said, let me tell you, you have a problem here, because insurance companies know to look for these cloned or copy and pasted notes. They know to look for it, and when they see it, that's going to decrease the value. It's going to have a negative impact on your patient, and if you've gotten paid on all those things, it has a very strong likelihood that you may have to give that money back. And P.S., you can't go back to the patient and ask them to pay you for it. So that's a significant problem. So one of the great things that's taken place in healthcare is the advent of electronic health records. As if patients know that when they go to an office today, sometimes their biggest complaint is the doctor spends more time with their nose inside a computer screen, typing away and clicking boxes than they do addressing the patient directly, eyeball to eyeball, knee to knee. There's a reason for that, because there is a lot that goes into it. But the advent of these electronic notes have made things very easy to just copy and paste from visit to visit to visit. And while I know in the world of physical medicine, things may be repetitive, we want to make sure that something is going to be different in that note. Make it look like a real live human being had something to do with the creation of that note. And that we want to make sure that the note can pass what they sometimes will call the sunshine test. All right.
Oh, what's the sunshine test?
Sunshine test is where at the insurance company, they literally will print your notes on a piece of paper. They'll take one date of service and another date of service, put it together, and they'll hold it up to the window, right, where the sun's coming through, and they'll see, do these 2 pages look exactly the same?
Oh, wow. Okay, that's interesting. I never heard that before. That's great. So I'm sure with your clients, you give them maybe checklists, or you teach them how to make that change, how to document the change from one visit to another. What are the things you want to look for? Because there's a lot that could be different that day in the patient, and you can't write down everything. Maybe it's not practical, but it's important to have certain key things in there.
From my perspective, even if what we do for the patient in terms of the treatment is the same or even just very similar to what was done previously, I like to make sure that there's one component of that note, the subjective. What did the patient tell you about how they're doing, ideally functionally? And make sure that that is unique and different on each and every visit. Inside of a phase of care, treatment might be very much the same. But what can and should change is how the patient is presenting to you and what they're relating to you. So many times a patient will come in and say, I'm feeling better, I'm feeling worse, I feel no difference. That's not enough, okay? We want to say, okay, now that you're feeling better, Mrs. Jones, what do you notice that you're able to do better or more easily, right? And if she can't think of anything, take a look at your previous documentation. Take a look at those outcome assessment questionnaires and see what it is that she reported that she was having difficulty with previously. If the patient's feeling better, that's awesome. What do you notice that you're able to do better or differently? And if the patient's feeling worse, which can happen, when did you notice that? What were you doing right before? What were you doing right when you noticed that the pain was coming back? And put that down. So patient reports increased low back pain after vacuuming their living room yesterday. Or patient reports decrease in headaches, was able to sit at their computer and work for 30 minutes without increase in their headache and neck pain.
Right. So one of the things I've traditionally done, I've asked them, are you able to sit, stand, walk, bend better today than you were the last visit? Are you able, if they're a construction worker, how's things going at the job? Are you able to complete your job? Do you have to take more breaks? Things like that, I think, carry a lot of weight. And then also, as patients get better, you can change treatment. You can do more stretching, deeper stretching, more range of motion. And if they're not getting better, then they could be referred out for other testing. So really, the note is very important for the patient. That's who it's the most important for. One, we want to get the patient better, and we want to do it in a way that is most efficient as possible. And if they're getting better, well, then great, maybe more of that, right?
Right.
If they're getting worse, well, maybe less of that and maybe something different, right?
Correct.
And this is just common sense. A lot of what this is that you probably find when you step back from it it's probably kind of common sense. Hey, something's working, keep doing it, right? And maybe step it up. Something isn't working, stop. Red light.
And one would think that that's the case, but sometimes we as doctors, when we're in the middle of it, when we're inside that box and we're busy with our patient and doing things, one after the other, and there's all these different requirements, it's very easy for us to create habits that to us in that moment make sense. But if you've ever had a chance to take a look at the documentation from another doctor's office, it can be very easy for you to say, I can't believe they did that.
Right.
You can poke holes in their documentation very easily.
Right.
Not that my goal is to poke holes, but I want to make sure that we tighten up the documentation.
Yeah.
Make sure that there's no opportunity for those holes to be created in the first place.
And in all fairness, when you're treating patients, no matter what specialty you are, you're thinking of so many different things that go through your mind. And sometimes you have to step back, like what you just said. But the thing I like about speaking with you, Jeff, is that you're the coach that can be another set of eyes, another viewpoint, vantage point, to have you come in and audit files or to give suggestion and help to doctors that are busy, that want to help patients get better, that also want to help them not only physically, but they want to accurately describe their accident. They want to make sure that they have the important pieces in the file, so it tells the accurate description of what the injury really is. And that's important whether or not the patient, it's important for the patient, it's important for the patient's attorney, it's important for the next specialist that the patient might see. And it's important for the insurance adjuster that is reviewing the file, because in all instances, they want to help their claimant too, their client, their insured. They want to help them as well. They're not always out to get the doctor, or always out to get their insured. They just want to make sure that the treatment is appropriate and that the record documents what's out there. And I think it helps us work all together. And it is hard. It's not easy. But something happened in the last few years that I want to see if you think we can do things better, easier. AI. ChatGPT, Anthropic. How can we use AI now as providers to be able to do our notes better?
One of the things that's super exciting right now is exactly that. There are a host of different external programs that a doctor can subscribe to that are pretty inexpensive. I've seen some that are like $99 a month, and you can utilize that for unlimited patient encounters. And now what I'm starting to see is the trend of many of the electronic health record programs themselves are coming up with integrated AI platforms. So it makes it easy. Now the doctor no longer has to have their nose in the computer screen typing away, seemingly not paying attention to the patient. Now we can have a conversation just like you and I are doing right now. And the AI microphone is picking up on our conversation, and it learns to weed out those elements that are extraneous. So if we're talking about the weather or the football game or whatnot, it'll leave that out, and it will talk about what is pertinent in today's visit and can create that customized note each and every time.
Okay. So are there any hacks out there or recorders or anything that we can get that you've seen, or maybe you recommended to your clients that can help the doctors be more present with their patient?
So if they are utilizing an external program, that can be a great thing. And many of them make use of an app that you can download onto your phone. And I've seen even a couple of the electronic health record programs that are doing the exact same thing. When I first heard about that, my radar went on full blast, because
privacy,
as a compliance guy, if it's on your phone and that phone leaves the office, what could happen? You can get hacked, you can lose the phone, and that becomes a HIPAA or a privacy nightmare for people. So the programs that are great that are on the phone will take the encounter, it'll transcribe it into a Word document that will be emailed to the practice. Then the doctor can review it, make any corrections that might need to be made, and then it's copied and pasted right into the patient's EHR, and it literally can do things in a fraction of a second compared to what it was done otherwise. And as soon as the app transmits that note to the doctor, it deletes itself off the app.
Wow. So, hey, if there are any chiropractors, physical therapists, or medical doctors out there that want to get more information about how you can look at using AI to help you document better, be able to spend more time with patients, and be able to get out of the office sooner, not as many late nights, not as many weekends doing charts, give Dr. Lewin a call. How can we reach you if somebody wants to contact you and learn more about what you do, the consulting services?
Super. So you can email me for sure. My email, really easy. It's drjefflewin@gmail. So drjefflewin@gmail.com. Or you can reach me on my cell, which is either in my hand, in my pocket, or sitting right next to me on my desk. And you can feel free to reach out to me. Just mention that you heard this podcast. And my cell phone is 954-205-3479.
Okay.
So feel free to
great.
reach out anytime.
And you know what, folks? In the show notes, we're going to have his contact information in case you want to get in touch with him. I think it's vital today. It's better care. Listen, better records equals better care, and also making sure that the patient is able to get it at a more effective cost, and then also making sure that their injuries are represented in the most accurate light, especially if they're having a medical legal issue or circumstance. You want to make sure that we're being accurate. Okay, now, before we go, I have a couple of lightning round questions, okay?
All right.
Documentation, myth or fact? If it isn't documented, it didn't happen.
Oh, that is absolutely the truth.
Fact.
It is a fact.
Okay. Longer notes are always better.
Definitely a myth.
Okay. Every patient should receive the same treatment plan.
100% a myth. And if they're doing it, understand that insurance companies are using AI right now to identify that, and that is squarely in the center of their crosshairs right now.
Okay, so that is a myth. And hey, if you're a provider out there, AI is watching and they're using it. So just be careful. Make it easy. Call Dr. Jeff. More diagnoses on your notes and HIC reform is better.
I say fact.
Okay.
The more complete that you can describe what's going on with that patient, the better it's going to be, the more accurate picture you can paint.
Okay. AI will soon replace documentation.
I don't know that it's going to replace documentation, but as we talked about before, it's definitely going to help make it easier. There's no doctor likes documentation. And I think that this is something that as it gets better, and it's improving every week, I think that this is going to be something that people are going to learn to embrace.
Okay. And every visit, every orthopedic test that was done in the initial exam should be done again.
Definitely not. Myth.
Okay. Awesome. Well, I want to thank you for coming on the show. And we have a little tradition here at the Injury Podcast. We give away to our guest a superhero tumbler. And the reason why we do is because to us, it signifies comeback, resiliency. It's like a memento, souvenir of being on the show. We are thankful and grateful for having our guests come on and help our audience with tough questions in this space. And I think that it's something that we embody. It's what we're about. So I have several superhero tumblers. I have Batman. I have Thor, Captain America, Wonder Woman, Deadpool. I also have Hulk, not here right now. And I have Superman. Which one speaks to you the most?
You know what? I noticed it when we were getting ready to sit down and do this recording, and the Batman one definitely speaks to me.
Awesome. He's a cool guy.
He's a cool guy.
Great parties.
Absolutely, and brings back memories back from when I was a little kid watching Batman and Robin, and that was what it was all about.
Awesome. Well, folks, thank you very much for watching. And until next time, same channel, what was it again? Same channel, same time.
Same bat time.
Same bat time. Okay, awesome. Thank you very much. And like I say, also like, follow, subscribe. See you on the other side.